All right, so hopefully nobody carb loaded this morning before this morning's sessions and things, so it's good to see such a nice full room, and we'll get started. So, transient responder. So we hear this term a lot, right? So, and when you hear the term, you know exactly what to do. The problem is recognizing the patient and being able to identify that patient, because we're really conditioned to try to make everything in our mind when we see it. Our natural tendency as humans is to make it normal, right? And so it's that allowing that little bit of questioning, it's that spidey sense of, oh no, that one thing, that one drop that actually was significant. And so as we go through this, I want you to think about, because all of you have a lot of experience in various areas, and I want you to think about, was there a time maybe that I could pick this up a little earlier, and what are some caveats? And hopefully I'll give you a couple maybe tools, because we're really good at, if it meets a criteria, we're really good at that, right? The checklist, the calculation, the whatnot. So what is the transient responder, right? So we really want to make sure we can identify that patient and identify them before they become the non-responder, right? It means the patient's bleeding somewhere. Somewhere they're bleeding, it just may not be obvious as to where. Or it may be that, it's multiple small sources, and therefore that's how we minimize that, right? So your goal is, and really when you talk about what could this talk be, it's identify the patient, find out they're bleeding somewhere, find it, stop it, fix it, and then that's it, the end. That's really what this talk is all about, right? All right, but identifying the patient isn't always that easy, right? Sometimes they don't show up and announce themselves. Hello, I was out there, I was in a wreck, I have multiple long bone fractures, and I'm bleeding there even though my chest and pelvis and fast look good, right? Sometimes the situation can kind of mask itself, right? Those kids, they kind of hang out, they look good until all of a sudden they don't look good at all, the geriatrics, right? Sometimes we allow it to be masked by things, I think their somnolence is, maybe it's a head injury, maybe it's drugs and alcohol, when really their somnolence is because they're not perfusing their brain, right? And sometimes it's, the mechanism, you just don't expect it, right? The fall from standing, good God, how badly bleeding can they be, right? But we're starting to see more and more, especially with the aids of pharmaceuticals, we're seeing more and more people with minor injuries be able to bleed a lot. And from what I understand here in Arizona, you guys are starting to really own the world of geriatric trauma, right? And so you're seeing those people, one little crack in the pubic symphysis, and they're trying to bleed to death right in front of you. And you're like, holy smokes, that shouldn't bleed that bad, but they can, right? And then there are those special populations. Again, the geriatrics, the pediatrics, but I would tell you the morbidly obese. It is amazing how much blood you can put into that soft tissue. And so we go through and we see these big contusions or we see a hematoma, but we're not conditioned in our mind to think, holy smoke, spleen, liver, pelvis, we're on it, right? We know, that can be a liter of fluid. But sometimes that soft tissue, you get a big seatbelt sign or a big bruise, you get a big hematoma in the abdominal pannus and a big hematoma in the thigh. And all of a sudden you've got multiple units of blood that you're not even thinking about that can possibly be a place where they can lose a significant amount of blood. So there are some patients that come in, it's really easy to figure out, they're not hurt, right? So 25 mile an hour MVA, young person, no comorbidities, lateral impact, vital signs look great, neck and arm pain. This one's easy. You all know this patient's not sick, right? So you do your workup and that's okay. And then this one's easy too, right? 35 high-speed MVA, frontal impact, unrestrained, bad GCS, hypotensive, tachycardic, class 4. This one's easy, right? This one's easy. This is the one that rolls in and it is game on. Everybody knows exactly what to do when things go well, right? Big abdomen, deformed thighs, people know bleeding. You're hitting the door and people are boom, 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 and they're giving the blood and the FFP and the plasma and the cryo and everything's going great. But these are the harder ones. 67-year-old, on Plavix or maybe on Eliquis, moderate speed MVA, restrained and had airbags, right? So should be protected, but also has COPD and has coronary artery disease, says he doesn't hurt anywhere, but blood pressure's 102. But what's his norm, right? Because if his norm is 180, 102 is a big problem. But we're so conditioned, well, it's not less than 90. I've seen people, and I'm sure you have too, where, pressure's 94. They're okay, right? We're very good at, it wasn't less than 90, so they must be good. I don't know what magically happens right at 90, other than that's what's in the box and on the paper. But I mean, you can have the same patient, blood pressure 92, 92, 92, 92, and it's 88. 88, oh my God, and everybody starts freaking, they're running around now. But really, there was no change in that patient very much, right? They've always been sick, right? And then they drop their pressure once, after fentanyl. And how many times have you heard, either rolling in the door or in the trauma bay, when somebody new comes in, your hand and report out, well, they've been okay. They dropped their pressure once, but it was after morphine. Or they dropped their pressure once and it was after fentanyl, right? I want you to think of that. Every time someone says that to you, I want your anal sphincter to tighten up just a little bit more to worry about this patient, okay? Because they're telling you something. Right? Their SVR, their arterial side is over there going, hang on, guys, hang on, right? And then they get that vasodilatation of the drugs, and they vasodilate, right? And then they compensate again. But that was your sign. That's your sentinel event, your sentinel bleed, right? So they're telling you, I'm compensating, but give me a little more time, or push me a little bit more, and I'm not gonna, right? All right. Whoop. So this is my nightmare patient, right? I think this picture here, this one over here with the guys on the electronic scooters doing a race, I think that's from Arizona, right? So I think that's right out here on the golf track, so, right? But it's the low or moderate mechanism with the older patient, or it's the high mechanism with the young, but the patient looks good. And you hear everybody, they look good, right? You can't really, their legs aren't deformed, their belly's not big, and they look good, right? But there's a lot of places that we can occultly hide blood. Or we may have lost blood before they get here, and now they're not bleeding anymore because they've bled so much, now they've sort of stopped, or they clotted temporarily, right? And that, again, that soft BP, or that one drop in BP, really should be an alarm to you, right? We want to believe everything's fine. When it looks okay, you really don't want there to be a problem. And sometimes our situational awareness and that heightened spidey sense, because we do this again and again and again and again, we just don't see it right away. And so I just want to refresh you all, really. Think about the physiologic system, right, as a well and a whole irrigation system, right? So the well, where the fluid is held, where the blood's held, your reservoir, that's your preload, right? And then your heart's the pump. And then your vessels, your afterload, are like the arterioles, and that's like the hose going out to the garden, right? So here's how we compensate, right? If your preload is low, if your well is dry, then the heart tries to pump and increase, right? So we increase heart rate. Then on the arterial side, we vasoconstrict, right? And then those meds cause that transient vasodilation, and now all of a sudden you drop your blood pressure. But what we tend to forget is that the well is dry, right? We got to think about, why is the well losing its blood, right? And how do we get it refilled? So does one drop matter? This was a great paper. I love this paper. So there was a study that looked, it was a prospective observational, it was blunt and penetrating, right? And they looked at patients who had one isolated drop in blood pressure, less than 105. This isn't even less than 90. It's less than 105. And it predicted the need for emergent intervention. And look at the times. 38% of these patients required some kind of operative intervention. Now, it wasn't always a laparotomy or thoracitis. Sometimes it was, fixation, of a long bone, or control of some hemorrhage, or something on the scalp, right? Remember, the scalp, you can lose your entire blood volume from your scalp. We tend to underappreciate that as well, right? So, 12.4 times more likely to require some sort of intervention than those who never drop their blood pressure less than 105. How many times do you get excited about a blood pressure of 105? Very rarely, right? That's really not in our, now, 88, holy smokes, we're bringing out the big guns, right? But just think about that in the mind. So is it sensitive enough? And there's some other literature, right? It's been the criteria for a long time. We all know it. But when you looked at this other group that came out, and they looked at if a patient had a blood pressure less than 110, mortality went up and your infection rates went up, and these are patients that required emergent laparotomies. Right? Another one that looked at blunt multi-center trial, looking at blunt patients, and again looking at that 110, right? And their mortality was double if patients dropped below 100, and it tripled when they dropped below 90. So maybe 90 is really too low. Maybe we really need to start really pushing things along when that heart rate's or that blood pressure's 110, right? And then your risks really went up when it was less than 70. So maybe we shouldn't wait till they get less than 90, right? So is there anything else that kind of nudge that, put that forward in our awareness, right? And this is a tool that I think is easy to remember, is easy to think about, and it's talked about a fair amount. You'll see some people who are like, oh, we don't need that, you just know that. But I think we all in the middle of the night need something that's simple that we can look at that then is a trigger, right? It's like that alarm bell, right? So shock index, it's heart rate and blood pressure, right? So if your heart rate is higher than your blood pressure, if that's greater than 1, that's bad. Right? So if your heart rate's 110 and your blood pressure's 100, that should heighten your awareness that this patient very well may be bleeding somewhere. And when they compared this shock index to looking at blood pressure less than 90, it was much more sensitive in picking up those patients that were going to require some kind of intervention, right? More sensitive, but less specific. And that's okay, because what we want to do is we just want to be aware of, and then we want to find the bleeding, right? So, and it was associated with these other markers as well. And if you use it, some people say, well, can you start over-triaging patients? Maybe, but that's okay if we over-triage. It's what you want to do. You want to decrease your under-triage. And by adding shock index, this center was able to decrease their under-triage rates. So I encourage you to think about it. It's quick and easy. I am a terrible math person. I always have been. I have a kid now that's in 5th grade. He's like, Mom, can you help me with my math homework? I'm like, absolutely not. You should go talk to your father, right? So, I still sit there like, okay, 13, 14, 15, 16, right? And I can do shock index, so you can do it. And does this work for the kids? And the answer is yes, right? Now, you got to remember, so this is something that I would have to write down or put on an index card, right? Because it does change by sort of the age and things. But when they looked at it in this group, you were able to predict patients who were going to require interventions, need for intubation, need for blood, right? And it outperformed just using, again, the vital signs, the standard vital signs. The downside is it is more math, right? The kids are always hard. What about lactate? Can you use lactate to identify some of these people? And the answer is yes. So ED lactate versus systolic blood pressure, right? And we know that if it's better at predicting the need for blood, and it's better at predicting mortality. And this was looking at both looking at an elevated lactate in a pre-hospital setting, as well as looking at it with a systolic blood pressure of 90 to 110 in the ED. And then looking at lactate greater than 2.5. Again, better predictor of patients that were going to need some kind of blood transfusion and intervention. So lactate can be very helpful. Does lactate work for kids? And again, the answer is yes. So, pre-hospital elevated lactate is predictive for the need for a higher level of care, need for intervention, and need to go to the ICU. So, let's shift gears. So we talked about how to find the patient, right? How to identify the patient. Some other tools that we may use other than just blood pressure. So now what do we do about finding the bleeding? Well, keep it simple, right? Start looking. We're very conditioned to the chest x-ray, pelvis, fast exam. But think about it. Do they have a big scalp wound? This tends to get underappreciated. It's very sad, but once a year, we still have a patient, usually an elderly patient, who's on some sort of Plavix, aspirin, Eliquis, something, who has a scalp wound, who everyone kept putting towels around the scalp wound. And we have West Virginia is an interesting state. It is not uncommon in the winter for pre-hospital times to be 4 to 6 hours, right? And so by the time they get to us, they've exsanguinated from a scalp wound. We really shouldn't have that happen, right? So I encourage you, no matter where you are, level 4, non-designated, clinic, somebody comes in with a scalp wound, whip stitch it or staple it. Even if it's dirty, then just leave a note, let people know, let them know on the phone, and they can take it down later. But that tamponade effect on the scalp wound, you could save somebody's life. And it doesn't take a lot of expertise to do that, right? So little scalp lacerations get underappreciated, because you've got patients on anticoagulants, or you have that little old patient, oh, she's tough. She lives on her own. She's really strong. Well, she was really strong until she fell down and got the 3-centimeter scalp wound, and she bled, a unit or two, and her EF's 10 or 15%, and, on a home O2 and everything. And those people just don't have the reserve, and they don't bounce back well from any degree of shock, right? So the idea is stop the shock, right? The other caveat, the other place I've seen things, under the collar. People get nervous, particularly if you're transporting them to the level 1, or they get to the level 1, we're so focused on chest, abdomen, all this stuff that we tend to miss the big laceration behind the neck or under the collar or here. So look under the collar, right? And then the other one that gets profoundly underappreciated are the patients, particularly the little old patients on the anticoagulants, who have 2 humerus, radius ulna, and a femur, right? That can be potential exsanguinating hemorrhage for those little folks. So think about that. Even though the torso, they don't have non-compressible torso trauma, that they could be bleeding to death from all those small fractures, right? And then go back to your ATLS, right? Some of these things are the things that you're very well trained and you're good at, right? Your primary adjuncts to your primary survey, right? And remember, you're doing these for screening, right? So if it's not the perfect chest X-ray, that's okay. You're looking for the big hemothorax. You're looking for this big open book pelvis, right? You're looking for the positive fast exam. So, and just, because I know we've got a lot of different folks. We hear about a positive fast exam, and so here's the kidney, right? And then here's your liver tip floating around in this black spot here. That's what we talk about. That's what we mean when we say positive fast exam. So that's fluid in the abdomen, okay? And then we've forgotten about the DPL, but sometimes you still need to use a DPL. So then the question is, to scan or not to scan, right? How many times have you been, how many ED nurses do I have in here? Yep, good. You guys are saints, okay? ICU nurses are too. In fact, all nurses are saints, right? So anyway, so how many times have you been there in the ED, you had a patient, and something just isn't right? They didn't hit that 90, but maybe they were 105, 102, and their heart rate variability is kind of going up and down. Something about it's telling you, And then we say, okay, we're going to go to scanner, right? And all of a sudden, your anal sphincter's like a possum eating a persimmon seed, right? And you're like, whoa, this seems like a bad idea. I don't know how many of you have seen a possum eating a persimmon seed, but it's really sour, so it puckers up really big, So, here you are, you're in the trauma bay, you got a normal chest, normal pelvis, negative fast, And I want you to think about, am I going to get in trouble if I go to CT, right? Is it safer to go to CT? If so, can you make things worse, or do you need to make sure you take the blood and take your products and make sure somebody stays with them and things, right? Were they unstable and now they are stable, but that's because you just gave them 8 units of product, right? That's not really a stable patient. Just because you had 2 sets of vital signs that now look okay doesn't mean they're stable, right? And so, think about, how did you get to that point? How did we get them so their vital signs now look okay? How long have they been stable? Because if it was just 2 readings on the blood pressure cuff, you're going to be halfway between your ED and CT, and they're going to drop their pressure again, right? And then the big challenge to the surgeons in the room, the decision makers and the ED physicians and the trauma surgeons is that information really going to help you, right? Do you have other explanations? Do they have 5, both femurs and both humerus, fractured, and even though their chest and pelvis looked okay? Or do you really need to know because it's something that you think is in the retroperitoneum or you're worried about an aorta? And so think about, are you going to gain something out of going right now? We do it out of habit, right? Because, they come in, they look okay, we go to scan, then we go to wherever we're going to go. That's just our routine. We're very good at routine, right? But sometimes you need to stay in the ED a little longer. Sometimes you should go to the ICU first. Sometimes you should go to the operating room and then go to the scanner, right? So think about what information is going to be gained. Do I need that information right now? And the scouts have it right? Be prepared. So when you go to CT, don't set yourself up for failure by going to the black hole, right? So you go, CT will take 3 minutes. Oh, come on now. It takes 3 minutes just to get the little lines to line up, right? Boop, 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 right? And it's always the patients you're nervous about. That it seems like it takes longer to get those lines to line up, and they're going in, and then they're going out, and they're going in, and then they're going out, and now you can't see the arterial lines, so now they're coming back out, right? And no matter what, I don't care how fast slice scanner you have, it's going to take you 20 to 30 minutes, if you're lucky, to get your scans done. Right? So have your meds, have your blood, be prepared, take your resources, make sure your docs are with you so that decision, if they do decompensate, is there. And you have a backup plan. If this patient goes south, we're either going back to the ED or we're going to go straight up. Right? And then make sure people are aware of the plan. Right? That's important. How many times have you, and you don't have to raise your hand, but how many times have you been standing there in the ED or in the scanner and you have that pit in your stomach of this is going to go south, right? And you just have this sort of sick, and you're like, man, I wish somebody would tell me what our plan is when this goes poorly, right? We've all had that sense. All right, so you all know this, right? This is what we're taught. We know the different classes of shock. And so one of the pitfalls, particularly if you're in a scenario where you may get patients that have gone through multiple levels of care, right? So initially EMS, then a smaller, maybe non-designated or a level 4 facility, and then to you, is they may have gotten multiple crystalloid boluses already. So one pitfall in resuscitation is figuring out how much blood they've lost, do they need resuscitated, figuring out your sources of bleeding, and then when do you need to give blood, right? Because maybe you don't want to wait, again, till class 4 shock, particularly in some of these older patients who don't have a lot of compensatory mechanisms. So think about all these places and ask and get in the habit, how much crystalloid do they get for EMS? And why? Right? Because sometimes it's, because they dropped their pressure there too, right? Sometimes it's because, trauma patient, we gave them crystalloid. Now that's going away. That used to happen a lot more, and that's going away. But just be aware. Document and communicate, right? This is one thing that the military does better than us, right? They'll take a Sharpie and write on a patient's shoulder, 2 units of blood, and then they get to the next level, and then 2 units of whole blood, And so they get to you wherever you are, in some tent somewhere, and you can see what they did. Now, we'd probably get in trouble if we did all that, but, you could write it down somewhere. All right. In summary, I want you to think about this. I want you to think about when all these patients come in, and I really want to challenge you. Next time somebody says, they dropped their blood pressure just once. But it was after fentanyl, right? Or somebody says, their blood pressure's, 98. They're fine, right? I've told my residents, nobody is fine. Fine is sitting at home on your couch, watching Oprah, eating bonbons, right? You are not, if you are in the ED as a patient, you are not fine, just by definition, right? And then by the end of that conversation, usually they're not fine. So it usually strikes home with them. But, believe the data. Think about shock index. Make sure you're following up on that lactate. How many times have you sent off the labs and sent off the lactate but never went back to look? Patient's still in your AD. You can be an important team member as that CA, nurse, respiratory tech who can, hey, doc, did you see this lactate's 3? Right? And it can be really helpful because sometimes there's a lot of things, and help and maintain that situational awareness for the patient is really important. Go back to the basics, right? Chest, pelvis, fast, long bones, scalp. Think about those things because those are all things and they can all be cumulative. A little bit of blood in the belly, a little bit of blood in the retroperitoneum, a little bit of blood in the pelvis, all of a sudden you've got, 5, 6 units of blood in different parts of the body. But one particular image doesn't look catastrophic, so we miss it, right? Don't overlook the obvious, again, the scalps, and resuscitate. Watch out for the crystalloid, because it'll kind of creep on you over, all the different handoffs. And then think about, whole blood, because that makes things a lot more easy than having to figure out how many, do we give this, do we give that, as our FFP thought and things. So I think the whole blood's going to be a game changer as it's coming out in various areas, and the data is very encouraging. So I really thank you for your time, and I thank you for the invitation. It's been wonderful. You all are a wonderful group of people, and I appreciate all the attention. Thank you.